I welcome all of you back to our YouTube channel Ignited Medicos. Today, in this class, let us learn about the hip joint, that is the competency number AN 17.1. I am Manoj, so let's start today's class. So, the exam tips. So, the hip joint is a major 10 marker question. If this comes for the exam, how you have to present it? So this is one of the most important thing that you have to know what to write and how much to write. Not to stick on one thing and you forget to write the other thing which is important. Like many of the students will write ligaments as an important thing. No, we should cover all other things also. Let's see what are the things we have to cover. That is, we should cover the type of a joint, articular surfaces, ligaments. Here don't stress more on the ligament. There are some other topics also you have to cover for a 10 marker. Let's see. Relations, burses, blood supply, movements, this is very important one, and the applied aspect or clinicals. So you have to write the applied aspect or clinicals to impress the evaluator and to gain the good impression. So in this video, I will explain you how much you have to write for a 10 marker hip joint. Don't add any extra, you just stick on how much I explain you. The type. By seeing the diagram, you can identify that it is a synovial joint of ball and socket variety. So this is enough to write an exam. So the next we have to move to the articular surfaces. The articular surfaces here are the head of the femur, and acetabulum of the hip joint. Head of the femur and acetabulum of hip joint. This acetabulum, it has three features. That is, it is a horseshoe-shaped lunate surface. It is a horseshoe-shaped lunate surface, an acetabular notch, and acetabular fossa. So in exam, it is enough to write head of the femur and acetabulum of hip joint. Okay, this is all about articular surface. The next is the ligament. Now let's see this ligaments via animation. The ligaments, there are 7 important ligaments here. You don't want to elaborate each ligament too much. Just write how much I tell you. That's sufficient. Okay, there are 7 ligaments. Let us discuss each of them. The first ligament that we have in the hip joint is the first ligament that we have in the hip joint is the first ligament that we have in the hip joint is the capsular ligament. Okay, it is the capsular ligament. So this is the capsular ligament. So this capsular ligament is strong and dense fibrous sac. This capsular ligament is a strong and dense fibrous sac that encloses the hip joint. Enough. Next we have this is the iliofemoral ligament. The next is the iliofemoral ligament. It is the thickest and strongest ligament of the hip joint. This is the thickest and the strongest ligament of the hip joint. It is inverted Y shape. You can look in this animation. It is inverted Y shape. It lies anteriorly. So this is the anterior view and it lies anteriorly. Right? Yeah. Its apex is attached. So this is the apex. It is attached to the anterior inferior iliac spine. It's attached to the anterior inferior iliac spine, and its base is attached to the intertrochanteric line of the femur. Intertrochanteric line of the femur. And what is its function? Its function is to prevent the trunk from falling backward. While walking, this ligament ensures that the person will not fall when he is walking. Right? So this is a very important ligament. The next ligament is the pubofemoral ligament. It also lies anteriorly and its base, so this is not the apex, it's the base. It is attached to the iliopubic eminence. Iliopubic eminence. Okay, yeah. And the next ligament, fourth ligament, is the ischiofemoral ligament. Ischiofemoral ligament. It is the weakest ligament. Okay, it is somewhat weak ligament than we compare to all this. Okay, it lies posteriorly. It is attached to the ischium. It is attached to the ischium posterior inferior to acetabulum. So this is the acetabulum, you know, and it is attached to the posterior inferior to the acetabulum. Yeah, to check the other three ligaments, I have removed the femur. Then only we can see all three other ligaments. The fourth ligament we have is the ligament of the head of the femur. So this is the ligament of the head of the femur. It is having the three slips, that is the posterior fascia, the intermediate fascia, and the anterior fascia. Anterior fascia, intermediate fascia, and the posterior fascia of the ligament of the head of the femur. As I told you earlier, it's a flat triangular ligament in which the apex is attached to the fovea of the head of the femur, and the base is attached to the transverse acetabular ligament. So the base is attached to transverse acetabular ligament, and the head is attached to the fovea of the head of the femur. The sixth ligament that we have to discuss is the acetabular labrum. That is the acetabular labrum. So this is a fibrocartilage rim. It is attached to the acetabular margin. So you can see this animation. It is a fibroelastic. It is a fibroelastic cartilaginous rim. It is attached to the acetabular margin. And the last and our seventh ligament we have is the transverse acetabular ligament. It bridges the acetabular notch. So this is the acetabular notch, and it bridges the acetabular notch. So this is the transverse acetabular ligament. So this is enough to write an exam. Just write whatever the points I explained. So the relations of the hip joint. So if you remember this diagram, it's very easy to remember the relations. So let us see. The anterior relation are the straight head of the rectus femoris. So this is the rectus femoris. We have already discussed, right? In the before videos we have discussed about all these things. Tendon of iliopsoas, synovial bursa, femoral nerve, femoral artery, femoral vein. So all the femoral nerve, artery and vein, they are the anterior relationship. And pectineus. So straight head of the rectus femoris, tendon of iliopsoas, synovial bursa, femoral nerve, femoral artery, femoral vein, pectineus muscle. So these are the anterior relationship. Coming to the inferior relationship, there is no much inferior relationships. Okay, we can tell it is as a obturator external. Okay, coming to the posterior relationship, it will be the piriformis muscle, sciatic nerve, obturator interna and gamella, quadriceps femoris, gluteus maximus. So all the structures that are under the cover of the gluteal maximus, you can write it for the posterior relationship. Coming to the superior relationship, so all the gluteal muscles, okay, that is the gluteus maximus, medius and minimus, and the reflected head of the rectus femoris. So the straight head is the anterior relationship, the reflected head is the superior relationship. So these are the relationships of the hip joint. The next is the bursa. So what you have to write in bursa? Just name them. That is sufficient. The first bursa is the bursa under gluteus medius. Okay, bursa under gluteus medius. bursa under gluteus maximus. This is the largest bursa, okay? And the next is the bursa under gluteus minimums. So these are the three easily remembering bursas. And one more bursa is the subpois bursa. Subpois bursa. And the last we have is the bursa between the gluteus maximus and the vastus lateralis. So there are five bursas: bursa under gluteus maximus, under gluteus maximus, gluteus minimus, subpois bursa, and the bursa between the gluteus maximus and vastus lateralis. So this is enough to write an exam. So the next is the arterial supply or the blood supply. Here there are five important blood supplies. That is the medial circumflex femoral artery, lateral circumflex femoral artery, obturator artery, superior gluteal artery, and inferior gluteal artery. So here this medial circumflex femoral artery, and obturator artery, they supply the acetabular branch to the hip joint. And the medial circumflex femoral artery, it forms the retinacular vessels. These retinacular vessels are the important blood supply to the hip joint. The medial circumflex femoral artery does this job. So another very important topic that we have to discuss is the movement. The movement of hip joint is very important. Let us discuss it via animation. So it is a multi-axial joint. So all the type of joints, all the type of movements can be observed in the hip joint. So that is the flexion of the hip joint. This is the flexion, and there is an extension of the hip joint. There is a medial rotation of the hip joint, and there is a lateral rotation of the hip joint, and there is the abduction of the hip joint, and there is the adduction of the hip joint. So these are the movements. So now let us discuss what are the muscles that are involved in this movement. This is very important. It's not only important to mention the movement, it's important to write the muscles involved in the movements. Of the muscles, the chief muscles involved are the pons major and iliacus. These two are the chief muscles. The accessory muscles for the flexion are the sartorius, rectus femoris, and pectineus. So the major are pons major and iliacus, and the association or the accessory are the sartorius, rectus femoris, and pectineus. Coming to the extension, that is the gluteal maximus and the hamstring muscles. So the hamstring muscles means that is semitendinous, semimembranous, and long head of the biceps femoris and the ischial head of the adductor magnum. So these are the hamstring muscles. So the extension is brought about by the gluteus maximus and the hamstring muscles. Coming to the abduction. Okay, the abduction. So you remember the muscles which are involved in the abduction are also involved in medial rotation. So you can write the same muscle names. So let us see. That is the gluteal medius and gluteal medius and minimus. These are the chief muscles, and along with that tensor fascia lata and sartorius. So these are the accessory. The main is gluteus medius and minimus. The accessory is tensor fascia lata and sartorius. Coming to the adduction, the name itself suggests these are the adductor group of muscles. Whichever the adductor group of muscles we had, that is we have adductor longus, adductor brevis, and adductor magnum. So these are the adductor muscles involved in the adduction. Coming to the medial rotation, as I already mentioned, the medial rotation is by the anterior fibers of the gluteal medius and minimus and tensor fascia lata. It is similar to that of the abduction. Medial rotation and abduction. Coming to the lateral rotation, we have here is a piriformis, obturator externus, internus, and camelli. Next is a quadricep femoris. So these are the lateral rotation muscles. So this is all about the movements. Move on to the clinical features. The first common clinical feature is the fracture of the neck of the femur. Fractures of the neck of the femur. So it is common in the individuals of 60 plus years of age. This can be of four types. That is Subcapital neck fracture. Okay, this occur at the head of the femur. Okay, subcapital neck fracture occurs at the neck or the head of the femur at the neck region. Transcervical neck fracture. Okay, transcervical neck fracture, it occurs between the neck and the intertrochanteric line. It occurs in between or exactly at the midpoint of the neck of the femur and intertrochanteric line. That is called as a transclavicular neck fracture or clavicle fracture. It's at the middle. Coming to the next is the intertrochanteric fracture exactly at the intertrochanteric line of the femur. And next is the pretrochanteric or subtrochanteric fracture, which occur below the intertrochanteric line. Okay, and this is having a clinical importance. As I already mentioned, the arterial supply, the main arterial supply for this hip joint is the retinacular vessels, which is given from the medial circumflex femoral artery. And you can see here, if there is, that is the subcapital fracture, okay, transclavicular fracture, intertrochanteric fracture, it damages this blood vessels, and there the necrosis of the head of the femur occur. But if there is a pretrochanteric or a subtrochanteric, this is a subtrochanteric. If the fracture occurred below the intertrochanteric, it is called subtrochanteric. If it occurs there, then there is no damage to the retinacular vessels. Hence, there will be no bone necrosis at the head of the femur. So this is very important clinical feature you have to mention in your examination. Other clinical feature is the coxa valga and coxa vara. So what is this? So coxa vara, these are the congenital disorders, which means it is from the birth. Okay, so here the first is the coxa valga. It is the increase in the neck shaft angle. This is the neck and this is the shaft. It is the increase. This is the normal. There is 130 is a normal. 120 to 135 is a normal. When if the neck shaft angle is greater than 135, we call it as coxa valga. Here the person cannot do abduction. So the abduction of the hip joint is hampered in the coxa valga. Coming to the coxa vara, here this is the decrease. So normally is 120 to 135. If it is less than 120, it is called coxa vara. The neck shaft angle is decreased here. In this case, the person can't do abduction properly. It limits or it hampers the abduction of the hip joint. So these are the clinical features of the hip joint. With this, let us conclude today's class. Thank you. Do like, share and subscribe our YouTube channel.